Welcome back, Titans, to another episode of EMS Lecture Series for SPC's EMT and paramedic programs. Today we are going to be talking about medical errors. Not a very fun subject to talk about, but as clinicians it's a necessary one. Over the course of your career, and it doesn't even have to be EMTs or paramedics, it could be nursing, it could be PAs or practitioners, and it could also be physicians. Anybody that comes across to evaluate, treat, or anything involving a patient can run into a medical error. Hopefully today we can go over the four main subjects, identify some pitfalls and issues, and hopefully prevent some in the future. So what is the number one? We'll start the video off with the number one medical error issue. It is communication breakdown. This is either not performing a cross-check for interventions or medications with your partner. This is not communicating appropriately with dispatch, receiving facility, med control, doing a consult. Communication error breakdown is the number one issue. So always remember good communication, closed loop communication, plain English, math, treatment modalities, everything should be on point. So let's break down the top four categories. It's diagnostic. That's where we're evaluating our patient, doing our testing. The treatment of our patient, after we've figured out what we need to do, how we're going to perform a treatment for our patient. Preventative, what we can do preventatively to not make our patients worse, and then a generalized subject of other. So let's get right into diagnostic. So number one for diagnostic is an error or delay in the diagnostic procedure. When we're performing a diagnostic test, it should be relative to the severity of the patient. If my patient, let's say, has chest pain, let's say 9 out of 10 substernal chest pain radiating to their left arm, obviously we should go down the acute coronary syndrome route and do our diagnostic testing. We should do a 4-lead and a 12-lead and do a proper patient assessment with our sample and OPQRST. But is there a delay? I shouldn't be waiting 10, 15, 20 minutes for that 12-lead EKG unless there's an outstanding issue. I should be doing that relatively quickly. We want to identify that myocardial infarction and identify what appropriate hospital and treatment we're going to give that patient. So we should watch out for the delay in our diagnostic treatments. Next is failure to employ the indicated tests. Now we've delayed a test. We want to make sure that we're not going to have a failure to employ the indicated test, like our 12-lead. Does our patient have chest pain? Not only should there not be a delay, we should also be doing that test. We should be following our protocols. If we have patient A that has chest pain, we should be doing the appropriate test for it. Number 3 is going to the use of outmoded testing or therapy. What does outmoded mean? So outmoded is basically anything that's obsolete or no longer in your policies or programs or procedures anymore. We should be following appropriate policies and procedures and treatment modalities and protocols given to us by our medical director or in your protocol book, your standing orders. We should not be using outdated items that are no longer relative or that are out of our scope. And finally, for our diagnostic is failure to act. This is a big one. Going back to our 12-lead EKG, if I find that my patient is having an MI, am I acting appropriately with that diagnostic procedure? Am I failing to act on, let's say, maybe you have to send that 12-lead to the hospital or notify dispatch or do some other procedure following that MI? Failure to act is going to be a big one. Let's get right into treatment. So now that we've gone over diagnostics, let's talk about the treatment category. Treatment is now that we've done the diagnostic and we've evaluated our patient, now we're going to provide some sort of treatment, whether it be administration of a medication or an intervention. So number 1 is going to be an error in the performance of an operation, procedure, or test. So is the test appropriate? Is the operation appropriate for this patient? Am I following my guidelines? Number 2 is going to be an error in administrating the treatment. If I have a treatment that I need to give, let's say we had our STEMI patient, our MI patient, is the treatment for that maybe nitroglycerin? We're going to vasodilate every 3 to 5 minutes if indicated. Am I following that appropriate treatment right, or is there an error? Number 3, there's going to be an error in the dose or method. This is a big one. The majority of the times that we run into medication errors involving treatment, it's going to be using the inappropriate medication, the inappropriate dose or strength, or not following our indications and contraindications. Anytime we're providing an intervention or a medication, we should be doing our medication cross-checks. We should also be evaluating our 9 rights. Per Nancy Caroline, the 9th edition, volume 1, has all of our 9 rights. Inside there, we also have a video on that before we do any medication administration. Delay in treatment. Just like we had a delay in our diagnostics performing a test, we should not have a delay in treatment. If my patient has my MI, is there a certain amount of time that I have to provide that nitroglycerin or that aspirin, or send that 12 lead to the hospital ahead of us so that they can get the cath lab ready, or whatever your protocol may be? We want to make sure that we're performing the right treatment at the right time, the right dose, the right testing, and the right treatment with no delay. We do not like delay. And inappropriate care. Obviously, we want to be cautious of the care that we're providing for our patients. We're going to be patient advocates for them. We're going to do the best we can to provide the exceptional care and consideration for our patients. That includes the right diagnostics, treatments, medications, communication to them, and also taking them to the right facility in which they should be going to. Finally, we have preventative. What does preventative entail? There's not a whole lot in here, but it's going to be preventative prophylactics. This is anything that prophylactic is anything that's going to prevent or protect our patient. These can be things like oxygen therapy for our hypoxic patients. Are we giving the right prophylactic preventative so our patient doesn't get worse? If they're hypoxic, obviously we don't want them to get more hypoxic, which could lead to further respiratory depression or respiratory arrest. So we're going to prevent these things, and we're going to be proactive, not reactive Titans. So inadequate monitoring. Preventative in the sense of we are always reassessing and monitoring our patients. We want a nice track trend guideline of how our patients are doing. Hopefully they're getting better. If we're continuously using preventative monitoring, we will be able to identify when our patient starts to say, let's oxygen saturation's dropping, or their pain is getting worse, or something like that. Finally, we have other. The last section of our medical error is going to be failure to communication. We said that was number 1. Appropriate, closed loop, plain communication can salvage a lot of medical errors. That's our cross checks. If we're going to a trauma center and giving our patient care report and our treatment modality and our story to our receiving facility, any red flags that we may have seen or issues that we may have come across during that call, communicating those to the receiving facility, to your partner in the ambulance, to med control if you're doing a consult, something like that. Communication is number 1. We can also have equipment failure. Obviously, hopefully, you're following your guidelines and checking your equipment either daily, weekly, monthly, annually, whatever the case may be. The better we check our equipment and we're up to date on the maintenance of it and the performance of it, the less issues we're going to have with equipment failures. But unfortunately, those do happen.